في هذا النادي، لأنه هذا الآن هي رسالة مننا لكم. هذا النادي العلمي كان بعد الله سبحانه وتعالى له الفضل الأول، إنه المملكة العربية السعودية دخلت المنظمة العالمية لجراحات السمنة اللي هو الإفس. ما كان يتم إنه في هذيك الفترة إنه هذا المملكة تدخل كعضو ناشط active not attendee active إلا في عام 2009. بسبب إيش؟ إنه كان في اجتماعات مقدمة، كان الجميع والنشاط. نتذكر اجتماعنا في كالجري مع الدكتور سلطان التمياط ومجموعة من الزملاء السعوديين، وليد البخاري وعدنان مفتي، واجتمعنا مع الليدر في ذيك السنة بالإفسو اللي هم ويليام جريب الجنرال سكرتري، وكان الإلكتد بريزيدنت مالفوبي. قالوا we need bylaws and a reference and a scientific activity or a committee or not a committee or a association for you to be involved. We don't take a random people. So بسبب انه هذا النادي الوحيد كان نشط في المملكة، جميع البايلوز في هذا الوقت كان عدد الأعضاء من فضل الله لهذا السبب أتمنى أن يرجع مثل أول وأكثر. كان عدد الأعضاء المشاركين 250 عضو أكتف، وهذول من جميع التخصصات. نتشرف فيهم زملائنا الجراحين، نتشرف بزملائنا طب الغدد الصماء، طب الأطفال والغدد الصماء كانوا يمثلون حتى بالفاوندرز. التغذية الكلينيكية كان لهم نشاط علمي قوي. نتذكر الدكتور باسم فوطة كان من الأوائل من التغذية الكلينيكية، كان ريبريزنتينج أرامكو. كان حتى الفيزيوثيرابي كانوا معنا، الإدكيتور كانوا معنا. فإتس مالتي ديسيبلين. علاج السمنة، علاج الطب والجراحة إتس مالتي ديسيبلين. We have to know إنه هذا منكم ولكم لن ينشط إلا إذا أرجعتموه مثل أول وأقوى. الجميع يشارك. فهذه دعوة من الدكتور أسامة ومن خلفه الجمعية السعودية لجراحات وطب السمنة، لأني كنت في المجلس الإدارة لهذه الجمعية. لن ينجح أي نشاط علمي إلا بتفاعل الجميع بكل التخصصات. ومن عنده أي موضوع علمي حتى يقدم، فالرجاء الاتصال باللجنة العلمية لهذا النادي، الدكتور أسامة، الدكتور عبد الحميد، معهم مجموعة من الزملاء مثل الدكتور سامي، مثل الدكتور عبد الله الغامدي، مجموعة. نفرح إنه الآن في كوميتي علمية ريفرنس والجميع يشارك. عدد اللقاءات يفترض أنها تكون 8 لقاءات حتى نغطي سنة كاملة. فأرجو من الجميع هذه المشاركة. الفضل الثاني لهذه الجمعية لهذا النادي انه برضه بالبايلوز بالممبر نيمز كذا كانت من الاوراق المسانده اللي اخذها. كنا بالفاوندرز انا والزميل الدكتور سلطان التمياط، وكان مجموعه معنا مثل الدكتور وليد ابو ملحه الله يذكره بالخير ومجموعه. كان سلطان قدموها الى الهيئه السعوديه للتخصصات الصحيه، فاسست الجمعيه السعوديه لطب وجراحات السمنه. فالان الرجاء اننا هذه الجمعية أسست أشياء كثيرة للبلد، لكن نأسى أوكي عام الكورونا 3 سنوات ما في أنشطة علمية، ولكن 4 سنوات كانت الأنشطة العلمية من عام 2013 و 2014 لين 2019 كانت سكترد، محاولات فردية. الشكر الجزيل وقتها للدكتور سلطان التمياط، عقد أكثر من اجتماع علمي. الجزيل الشكر برضه للدكتور أسامة، عقد أكثر اجتماعين علمية، ولكن لا ينفع سكترت ميتنج. خلاص الآن عندنا organization، عندنا club، we have to participate all، we have to attend all، we have to be active all. هذا بوينت. البوينت الثاني الدوكيومنتري. ترى عبد الحميد إذا أنا تجاوزت 5 دقائق ستوبني لأن البرزنتر ها كيف؟ تجاوزت؟ خلاص I have to stop، بس I have to mention very important thing. خلينا نقول انه جميع الزملاء الجري هيرز بعضهم ما شاء الله ستيل بلاك هير مثل الدكتور سلطان والجميع البلاك هيرز، عبد الحميد، اسامه، الدكتور سامح، الجميع نمد ايدينا جميع الزملاء. we need to document اي احد ما we will not be presented الا بالscientific presentation بالscientific paper publication باي شيء انتم you need it in the publication. Please don't hesitate to communicate anyone. We are parallel. We have to be in the same boat. We need this scientific activity on publication كdocumentary. شكرا جزيلا، طولت عليكم. Really, I am honored. أنا ما أقدر أقول إنه من عظام مركبة، لكن I'm really honored to introduce my dear colleague, Dr. Sultan Al-Timyan. As actually, if we will take a brief CV, it will take a big lecture, long lecture. But to know, Sultan is one of the founders in obesity medicine, obesity surgery in Saudi Arabia, one of the founders and lead. He's the first one, did the gastric bypass in Saad Hospital. A few time later, we catch up with him to do with Dr. Khalid Mirza and Ahmed Salman. Later on, Sultan have a very active and scientific. He lead the group he is the one who presented in Buenos Aires to present ourselves to be involved in IFSO. So the credit of membership of Saudi Arabia of IFSO is for Dr. Sultan Al-Timyan, one of the founder for the Saudi Obesity Society. And actually he participated actively in the Gulf Obesity Club and in the Eastern Province North African Association for the IFSO. So actually, if I will speak it's English activity and participation, I'm honored to introduce Dr. Sultan. He will present about the gastric band. And I will talk about I will discuss with the gastric band with at the end of the session. But please, all the questions should be at the end of the session. He will have 4 lectures continuously. Thank you.
Thank you, Dr. Good evening, ladies and gentlemen. It's my honor and pleasure to be here tonight, and I'm really happy to see my friends. Long time no see, and I hope that we can see each other in the upcoming meetings. Most of tonight will be history. So let's see what we have done in the past. And from the history, of course, we learn okay, do we have problems, Sarah, with Zoom, or we are okay?
Doctor, we are fine. Yeah, we are fine.
Okay.
We are okay.
And on the same time, for our colleague in other area in Saudi Arabia, they are with us on Zoom meeting. And this is my disclosure. I am Medtronic instructor and on the same time Ethicon speaker, but this is nothing to do with our talk tonight. As I said, most of our talk will be about history of lap band. If you want to go back to the history of the band, how did it start? It's very important also to know the history of bariatric surgery. So the early attempt of surgical options of bariatric procedure started in the last century, the beginning of the last century. But in 1955, the surgeon, they started to do malabsorptive procedure that time. They did the jejunal-ileal bypass procedure. And the problem of this procedure, it has serious consequences. So this procedure complicated by mineral, vitamin loss, protein, caloric malnutrition, and eventually liver failure. So this procedure abandoned that time, and in the early 60s, Dr. Mason from the state, he was an upper GI surgeon. He was doing lots of GI gastric resection for either gastric cancer or peptic ulcer disease. And the final construction of this procedure was an Billroth configuration. So this gave him the idea of the gastric bypass. So the first gastric bypass performed that time, it was one anastomosis gastric bypass. It was single anastomosis. As you can see, the pouch, it was horizontal pouch. And the gastric jejunostomy, it was a loop configuration. And it's very obvious that the distance between the stoma and the GE junction was very short. So this procedure complicated by biliary reflux esophagitis. So lots of modifications and changes were made to this procedure in order to minimize these complications. And almost took 10 years when Dr. Griffin from the state, he managed to do the what we call raw and white configuration. So no more reflux problem, and the pediatric community that time, they were really happy, and they started, especially in the state, in North America, they started to do more and more of gastric bypass. But at the same time, Mason and his group, they were not really happy. They felt they'd been defeated. So they went back to the stomach and they tried to do something. They call it Mason procedure. They want to do instead just restrictive procedure. So they don't want to have the mal-absorptive component of the procedure. They started with this is their initial procedure. And also failure. They had problems with the dilatation of the outlet. They had a problem with the reflux and also fistula, because they were dividing the stomach in continuity, they call it. The old staplers, they were not dividing between the 4 rows that time. And again, modifications to the procedure carried out, especially in Europe and Italy. And then they started to put the mesh, and they divided the stomach with better results. But again, that procedure was popular both in the States and in Europe. But another surgeon from Belgium, they thought, why don't we just adjust the outlet? We wanted something to control the outlet, because here they had lots of problems. So the idea of lap band started, and the first one, and there were 2 groups in Belgium. One, Dr. Pilashev is from Ethiopia. He's a great surgeon. He worked really hard on that, and he started his initial work on animal labs. And then he did the first one. It was open surgery. On the same time, Bernard Cadier and Jacques Empens from St. Blasius Hospital in Brussels, they did the first laparoscopic. They were young surgeons that time. And Dr. Pilashev was at his pre-retirement age. Was very difficult to recruit the laparoscopic approach. So those surgeons, they organized lots of workshops that time. I attended my first workshop was with them, and I was lucky 2 years later to join them and to have my fellowship in bariatric surgery with Jacques Empens and Cadier. So then that was in 93, by the way, 93, 94, they started doing laparoscopic gastric banding. So this is the initial procedure, and it was the company, BioEnteric company that time, and the American company. And there was also the Swedish type of band. They started almost in the same time. But I don't want to go into details. Maybe some of you, some of the surgeons here, maybe they never done band before, because it was a long time ago. But I'm sure they are managing cases now with complication of band, patients coming with problem of weight regain or complications. So the decision is very important. It's important also to know the type of the band, and some of the bands you start with the tube, the other it's the buckle itself, the orientation of the band, the approach. There was two approaches: perigastric, close to the stomach, and this complicated by large rate of erosion. So they moved to the perigastric approach through the pars flaccida, so far away from the stomach, and they just loop it behind the stomach at the crus. So this, with the other technique, the second technique, the pars flaccida, the complications were much less. So this is in 2001, no big difference, Sam. When celebrate my last day with Kadir and the group. Then I came back to Saudi Arabia in 2001, but people, they started already. So Dr. Walid Bukhari and Dr. Adnan Mufti and Dr. Al-Dhahiyan, those are the people who started the bariatric surgery. And they already started the laparoscopic approach, lap cholecystectomy. So they like the idea of the lap band compared to the BBG. But Professor Mufti, he did the first, this is for the history, he did the first bariatric procedure in Saudi Arabia in 1988. It was my second year student in the same hospital, the medical student in the King Saud University. So you can see the BBG. It's very obvious. It was open approach, and they did the procedure that time. And then he continued to do more and more of this procedure. And Dr. Abdul Hamid al-Momin, our colleague here, our senior colleague here, he was with the same group later on in the Security Forces Hospital. And you can see they have done 100 of these procedures. They did the BBG, they did all variety of cases, all type of procedures, but they were focusing more on lap band. And as you can see, oh, it's working. Where's the? I'm sorry. I want the pointer, but I don't know which one. Yes, okay. So 2,000, more than 2,000 procedures performed. This report, I have done it myself in 2009. That was 2009, maybe 15 years ago. They have done 2,000 procedures, a lap band. So what happened to those patients? So the lap band is still there. So patients, they will come back to us for another procedure maybe. Okay, in Jeddah, Dr. Walid Bukhari and Dr. Hammo, they did the first case ever in Saudi Arabia in 1995, lap band. It took them 6 hours, the first procedure, but they managed to do it laparoscopically. And later on, this is their numbers in 2009. Again, as you can see, most of the bariatric procedure that time were lap band. This is in Mecca, Dr. Zafar. This is his cases. And then we moved to Eastern Province. When I joined Saad Hospital in 2004, Dr. Abdul Hamid al-Momin was before, and he started the lap band, first surgeon who started the lap band in Eastern Province, maybe in 2000 or 2001. Abdul Hamid, 2001. Swedish, that was a Swedish type. So we were two different groups. Always we are not the same. So I was lap band and he was Swedish. Both of them that time were very good procedure. We have done like close to 1,000, myself and Dr. Abdul Hamid in Saad Specialist Hospital. Our colleague, Dr. Ahmed Al-Garzai, he was in a military hospital, King Fahad. He performed that time 550 cases, lap band. That was before 2009. And this is a National Guard hospital. You can see they were doing the procedure in Al-Hassa, not in Dammam. They started in Al-Hassa and then they moved to Dammam. They have done all variety of cases. Gastric band was also popular as a restrictive procedure, but then they focus on malabsorptive procedure, BBD. I received 2 patients today in my clinic with BBD with different problems. One of them, she gained weight with nutritional consequences of the BBD, and she asking me, I did BBD in the past also. All of us, we are doing these cases. But one of the difficult cases now, we are managing this malabsorptive procedure. So at Saad Hospital, we started, it was the booming of lab band at that time. I think it was between 2005 and 6, 7, 8, before we start the sleeve gastric. I'm sure you know these faces. Just for my friends who were in Saad, most of the surgeons here, they at one time they were in Saad Hospital. So this is my almost entire bariatric practice. As you can see, there is rise and fall of certain procedure at a certain time. And this indicate that there is none of them is perfect procedure. So we are doing many procedures in an attempt to fight the obesity, but always there is other factors, not only the procedure. And in my opinion, and we learn from our own experience, that the outcome in terms of weight loss, it's usually, most of the time, it's the response and the reaction to the patient to a given procedure. So sometimes we have seen, I still have patients coming to me with excellent result with lab band, still till now. And I had patients who came to us with weight regain with gastric bypass. So the commitment, the response to the procedure is variable between patients. And I think our role as a surgeon here, it's very important to do the procedure, the right procedure, and we should respect the anatomy whenever possible, and to minimize the complications. It's not, I don't think it's not wise to do a procedure for a patient that maybe you are sure it will lead to excellent outcome, but with nutritional consequences or reflux, possibility of reflux. Reflux is the serious concern that we are having now in the bariatric surgery practice. So as you can see, the lap band, it was maybe, I don't see very well, it was 2006 and then coming down. And the last one I do, it was in maybe 2016 or 15. I don't have any more band, but if you ask me, is it still indicated? I cannot say it's not contraindicated or absolutely, it's not recommended at least. Some of patients still, some of the centers still, especially in Australia, now with the excellent commitment and follow-up program, they still doing it and they still publishing the results. But they have dedicated team for this. And I remember when I was with the Carrier and Jack Embeds, they have team. They don't do anything. They just do the surgery. The follow-up, and in case of complication, they discuss with them. But there is other team, completely other team. They call it GI team. They do it with radial. They do everything, nutrition, adjustment, etc. But for us now, with the accumulating number of patients, it's hard, and it's almost impossible to have good follow-up with them. That's why we gave it away. We are the surgeon who gave it away. So this is my initial talk. It's part of the history, and then maybe I will share with you guys. It's not, I'm not happy about my slide tonight, but I'm happy to see you all here and to discuss again, to resume this activity. And I want to share with you some of the let's say, case scenario that we are seeing in our clinic, and maybe you are, and also I will share with you the management. But this is our algorithm for lab band. And as you can see, if the patient's coming to us with the problem of coming to us seeking another bariatric procedure, which we see with the patient having failure to lose weight or complications, or let's say weight regain. The failure to lose weight, we divide it in two arms. No weight loss. The patient, they did not do well initially with the lab band, and other patients who did very well in the beginning, but they had weight regain. So the weight regain patient, the weight regainer that we check if they did well initially. No GERD, one anastomosis gastric bypass is our procedure, preferred procedure. If there is any reflux or hernia, we rather prefer RYGP. And also remember that RYGP, it's extremely difficult if you want to construct a good pouch post-band, because you have to do it right. The pouch has to be small, otherwise you will not have the restrictive component of the procedure. And of course, one anastomosis gastric bypass is preferred because you will be far away from the band site, scar tissue, fibrous tissue, adhesion, so you'll be far away from that area. But in the past, we had excellent experience, honestly, with BBD following band, because surgical at least, because you are far away from that area. You resect the distal third of the stomach, and then you do the loop anastomosis, the stoma. We have two stomas there that time, alimentary, and we have the biliopancreatic limb. But the problem is the commitment. I have done like only 20 cases with those patients. Some of them I'm still following, but again, it was a difficult follow-up with those patients. Then we moved with the introduction of one anastomosis gastric bypass. It became the preferred procedure for us. For the complications, the complications merely erosion or slippage. People sometimes confuse between slippage and pouch dilatation. But erosion, we prefer just to do band removal, not to do other procedure. It's better you just remove the band, whether endoscopically, if you have endoscopic physician with good instrumentations, they can remove it endoscopically, or you can just go laparoscopically and do gastrotomy and just remove. In case of slippage, then you can judge, you check the tissue. If the tissue looks healthy, you are comfortable, then either you go for RYGP or MGP, depending on the other criteria, especially GERD and reflux. This is just definition for my colleague, the younger colleague, the newcomer in this field. Just I will try to explain some of the terminology. Sometimes it's misleading or confusing. Lab band erosion, when the band erodes inside the stomach, whether it's partial erosion or total erosion, and this will be complicated by migration. The band will migrate. The band can cause distal obstruction, even sometimes with the tube in place. Without tube, sometimes the tube disconnected, it's easy to migrate, but sometimes even if the tube there, because the tube intra-abdominal, sometimes we used to make it long, just in case you had a problem, you cut it and reconnect it. One of the complications that time, we had band related complication, and we had a tubing and reservoir complication. Disconnection of the tube, turnover of the reservoir, etc. So we used to keep the tube long in case we need it in the future. So this is the erosion, and the symptoms Some of the patients, sometimes asymptomatic. They just have weight regain and they come and they ask for another procedure. They have no symptoms at all, especially if it's total erosion. So that's why, well, not to have a surprise, we recommend and advise everybody and myself to do endoscopy. Prior endoscopy is very important. And you ask tell the endoscopy that the patient had a band. He has to look for it. Sometimes it can be missed. A big pouch or sometimes with pouch dilatation, they cannot see very well and they just go and they tell you it's okay, normal, and they give you the finding without saying a single word about the band. The pouch dilatation, as you can see, I will show you the X-ray later on to show you the proper position of the band. As you can see, this band is not the proper position. Always we like to see it this way. If you see it in the X-ray, like that, 45 degree, but this is opposite. Once it became like this, it will get obstructed, and the pouch on top of it, it will get dilated, and this will get bigger, and sometimes you see it like that. We call it, sometimes it's chronic dilatation, but once it become acute or sudden, then it will be emergency management. And this is a contrast study to show you exactly. And as you can see here, the band, it's here, it's not really bad, but I like to see it this way. Okay, 45 here, it's almost horizontal. So this, it will cause obstruction. When you have done the study, you can see it will get dilated here. Once this full, it will just pass, so that the liquid can pass with difficulty. So this is very clear, and you have to, and some of the patients, they are not happy. You deflate the band, but didn't help them much, but they do want to put weight, so they disappear. And then here the rest of obstruction and ischemia. This is from inside, as you can see. This is endoscopic view for the pouch dilatation. If the endoscopy, and he has to be very careful, endoscopy, not to perforate here because the anatomy is distorted and the tissue is inflamed. So here is just to show you the difference between dilatation and slip. Dilatation and the distance between the distal esophagus and the band is not far, as you can see here, but you see the pouch, and most of the time the dilatation is anterior. Rarely you see it posterior. So this is dilatation, but here is a slippage. So the band is slipped distal. Sometimes in the X-ray you don't see it very well, but what I do, I just check the distance. Sometimes if it's not obvious for me, I check the distance. This is more serious. So you can wait on pouch dilatation, but you cannot wait on slippage, because then it will be the blood supply will be affected, and then this might lead to gangrenous part. And I have seen it once. So just here, I think video. I'm sorry, can we dim the light here, or it's dim already? Here, I don't know if you. This is. I want volunteer here to read for me there. Okay, I'm sorry we have taken this video from our mobile from the machine. You see the contrast is it's not bad. Okay. As you can see, you see the position of the band. It's not far from here, and the alignment is good. There is no pouch, and it's emptying. This is most of the normal study. You see it this way. And here, what you can see, this patient who presented with abdominal pain and nausea, vomiting, food intolerance for a few days, and the band being deflated. He improved a little bit, and he came and asked you, when you check the after deflation, it looks okay, no problem. Maybe the band is a bit displaced, but then you discuss with him the option, the next surgical option. But when you proceed to surgery, this is your finding. I will show you the video. I want to see from my colleague who wants to proceed for another procedure or just to remove the band after you see the whole. It's short video. You see it nice? I have to stay here for the mic. This video I have taken it from my friend, Dr. Osama. But we will ask him at the end what he did for this patient. But as you can see, the tissue doesn't look well here, especially in that part. Maybe it's a bit edematous. And the band, if you want to remove the band, I'm sorry, I'm trying to repeating for my people who might not seen the band before, or they will be in a place to remove a band. That when you just stick to the band. Once you see the band, your diathermy on the band, you just follow the band and you will see. What will you do, guys? Anybody want to proceed for another procedure after removing this band? I just show you again. Or you prefer, who prefer to not to do anything, just to remove the band? Hands up. Okay, maybe 50-50. Okay, this is another patient. Again, this patient came with, if I still recall, food intolerance, reflux. And as you can see here in the CT scan, that the band, almost the whole band is there. Maybe part of the band is not there. I'm sorry for the video, but here it's inside. Again, you identify the band. Sometimes it's difficult. Once you see the band, you just stick to the tube can sometimes guide you to the position of the band. And we have, as we said before, we have the Swedish and we have the bioenteric. When you see the methylene blue, always the Swedish, because it's not radio opaque, usually they put methylene blue to show, not methylene blue, sorry, contrast to show in the X-ray. And then you just follow the tube. And you cut it in pieces. And this band partially eroded. The posterior part of the band is already eroded inside the stomach. And it's in the proximal place. So there is no way that you can just fix it and go proceed with the provisional surgery. Next movie, it's a continuation. Do we have here endoscopist with us? Huh? سالم سامي وين دكتور سامي كيف الحال I think he's the best one who can tell us how to remove it endoscopically. And I think there is just one instrument needed additional to the the conventional instruments that you are using just to cut the band and to remove it. And this is usually how it looks when you remove the band. Once you see this color, usually the color of the band should be white. Even if there is adhesion too much, it should be very clear like this. But once you see it very dark yellow or green, you suspect erosion. And migration of the eroded adjustable gastric band being reported many times, being band migrated, eroded, and then migration to almost everywhere to the colon and small bowel. Small bowel through because it was completely inside the stomach and then just passed the normal way and stuck in the ileocecal valve. Here, just to show you, you can see in the jejunal loop here, the tube, the band is the jejunum here, and you can see maybe the band in the distal area, and it's very obvious. They localize it and they did just small incision and they remove the band. These are some contrast study to show you the different position of the band. Sometimes when with the contrast you cannot see the band, maybe it's here, that can cause the problem, or maybe somewhere here. Here what you can see, as you can see, the band, that you can see the contrast is passing after deflation. After you deflate the band, it's passing, but there is pouch. There is a pouch there, and the pouch with the position of the band, when you see it this way, it's risky. Even if the patient is not having any symptoms, always recommend, if you don't see the band in right alignment and position, don't leave the patients and tell him about the risk of problem, obstruction. Sometimes it comes emergency, no surgeon, you go to the surgeon in general hospital, and then sometimes a problem happens. But it's good to have this procedure as elective surgery. You see also, I'm okay with time. Huh? Okay, oh, yeah, okay, we are finished. So this, you can see the position here of this band, and it looks very high there. And the alignment is not really good. Just to show you a study for you can see that it's on top of the band, nothing is going. And you can see big folds here. And the patient is having problem, having symptoms of obstruction, and she did not lose weight. She's not obese to start with, very obese. She had mild obesity when she had this surgery done. And it's very obvious that she had a problem. And this is inside surgery. You can see this is very interesting. You can see, you see the bandage here. Okay, once we start to dissect here, then you'll see the surprise, you'll be surprised but that the band is very loose here, big. And the stomach, part of the stomach going through the band and causing the obstruction. So I remember when, long time, when we had the band, we have to make sure that the band is in place. We do fundal suturing to make sure that the band, at least in the beginning, is not gonna migrate. So the same thing. Here, different position that we don't like to see. You can see, as we said, the band here. So I just proceed. This is another case with, you can see it in the jejunum, distal bowel. You can see the band eroded there. It's here. Now for the revisional procedure, this is what we have said before for erosion. It can be removed endoscopically or laparoscopic. This is the laparoscopic approach. You have you open the stomach there, and you may sometimes need to pass the scope inside if it's big stomach. You go distal because this can easily, you can close it and cut the tube and remove the band. I had experience in one case that I thought we did well, but eventually the patient had a problem with the bleeding caused obstruction at the biliary limb that we had to open the patients again. Here's some illustration to show the band. How do you do it? It has to be, if you want to remove it, you respect the anatomy there. This is the position. Usually the tube and buckle on the almost 11 o'clock position. So for I don't have much of time, but for revisional option, you can try any procedure. But I think converting the restrictive procedure to another procedure, it's not going to work if you remove the band and do sleeve gastrectomy, because we don't expect to have a good outcome. We always recommend to move to convert to add malabsorptive component to the procedure. Surgeon, they do RYGB or MGB, as we said in our algorithm, or even malabsorptive procedure like SADI or BBD. Revision of laparoscopic gastric banding, success and failure. Always we feel that we should discuss these things with the patients, among ourselves. Endoscopy is very important preoperatively. Endoscopy can change your strategy also. And I think we should rely more on the behavioral changes for our patients. For revisional cases, we make sure that they will have better commitment, and also psychology study is very important. I'm sure we have among us some of our colleagues, psychologists, and the nutritional part is very important. Do I have time for video? Last one, 3 minutes or 2 minutes? Whatever. This is the last slide, just to show you if you want to remove the band and convert it to gastric bypass. Maybe just I will show you only 1 minute. You go. This is just patient with weight regain, no problems. That time, this was in 2014, my video, old video. That time we did not recruit one anastomosis gastric bypass, so we had either BBD or RYGP. So we choose here RYGP. Again, this is because it's clear, as you can see, the tissue looks healthy. You just be on the top of the tube. It will guide you to the buckle that you need to either open it or just cut in between, and then you can remove the band. I can proceed with, and then you do your pouch. As I said, in RYGB, sometimes you have to be very cautious because there are lots of scar tissue and fibrous tissue there, but you have to do the pouch right. It has to be small pouch. I think I stop here. Thank you very much.
Thank you very much for the time. Sorry that short a little bit the time, but we did talk with the organizer that it would be a 5 minutes, I thought it would be 3 minutes, 5 minutes presentation for the company, so to present. But before we call it, if you can break with what with us, it is an open discussion for our colleagues that are any question for Dr. Park. Okay. Let me have a question for Dr. Park and for our colleagues to say. I understand that normal or direct time is the main time. Can we do a consensus that direct time is only that we did for the DPT?
هنا في مايك أسامة.
But if you look at all the things that are coming, there's a series of more difficult, and in addition to more difficult, I don't say, if you are on the building, do something that may configure the that's why that's my own file.
By your opinion, it's a fine. The last surgery for time in 2016 from your presentation. If I am a patient, comes to you, I'm well educated. Okay, and I have the knowledge and the wisdom. And my BMI is 31. I'm not diabetic, I'm not hypertensive, and I have a phobia from cutting my stomach. I don't want anybody to cut me. Do you offer me gun, glycation, endoglycation, or you give me, or you ask me to refer to our legal endocrinologist for September and December?
We will try everything possible short of surgery first. But if I decided to go for surgery, I think now sleep is very safe.
I have a problem.
Okay, I will. Yeah, but they think, okay, but I have to explain to them that the band on long term, it has its own complications. We have problem with the slippage, erosion, and it's a foreign body there. I will not do it, honestly. I will not do it. And I have to explain to them the fear is not justified. Sleep now, what's the, in the beginning, I don't like the idea of sleep. I didn't like the idea of sleep that time, RYGB, that time, because the leak was a serious complication. We had 5% rate of leak. I remember one of the hospital, 25%. Now the leak rate is maybe 1 in 1,000. So I think it's safe, but the patients, maybe they don't know. If you explain it this way, on the same time, you explain to them the long-term possible complication of band, then they choose.
Let me have an answer for this question from the patient. Yes, no, I will do, I will not get time. I have to you me time, I ask you for that. You will not do it. You will tell me. Man, you will tell me, you will not do it. I will agree with this guy. Okay. I'm very happy with the past some party usually the presentation that we let the patient, we did the last time for no complication. Okay, if you have an interpreter for persons like the Swedish or the Australian, we have it in our internal case. So we have to respect the patient's question. We are, as a surgeon, advising, but we cannot force the patient to do or not to do.
No, there is no. Of course, I agree with you, Ahmed. But for surgeon who did not do band before, they will never ever think of band. Okay, maybe 90% of my colleagues now, they never done band. They are managing complication of band. They will never ever think of that. For us, the surgeon who did thousands of the band, and still we are saying no.
What is the evidence-based medicine? Long-term complications of band compared to sleep. Actually, what is the long-term result of the band? Okay, and regain. The long-term result, they regain 70% of the people. Right? In our country, sleep, they regain only 40%. Come on, because we give the patient the sleep is political. For that reason, I'm happy this evening to present this picture to give a message. It is a valid option. It is a valid option because from your presentation, you give an excellent result. Also, here we highlight the complication, we highlight the revision, but it is an excellent provision for the patient who would comply and educated to come for adjustment and action. Am I wrong?
Yes, if you agree, Ahmed, you want to do the band, I'm sure all of us will send those patients to you.
Thank you.
Really, honestly. We ask any patient who's insisting, it's nice to have one center in the area, want to do this, but with commitment. If there is a good commitment, why not?
Absolutely. I'm happy. And the last patient, this is important. So when we look at the offer, okay. I have a question on the revision. Now we'll ask the revision. I want to question the profile revision. Thank you.
Yeah, it's an option, and many surgeons they are doing it, but you know the problem that if you look into the literatures, people they don't report the bad results. If you see good paper, somebody who he did good job, but most of the surgeons that this is just observation. When you talk to them, senior surgeon, pioneer in this field, everywhere, they tried because the patients sometimes they ask for sleep. They are not happy with the outcome following sleep. And it's maybe it's a two-way. Some surgeons they just wanna play it safe because when you remove the band, lots of scar tissue, fibrous tissue there. The risk of leak will be higher if you want to do proper sleeve. If you want to do it tight, really tight, the risk of leak will be higher. So some other surgeons, they just want to play safe. Okay, I don't want to take the risk of complications. And I have explained to the patient that the outcome is not really good. And they go away from, when they reach the fundus, they go far away. So they left part of the fundus there. So you will have problem, especially reflux. So personally, I never done a single case from band to sleeve. Even on some of the patients, they refuse because I know the outcome, it will not be really good. So I always try to choose between RYGP or one anastomosis gastric bypass. Some other surgeons, they prefer to go even for more malabsorption. But if you are happy with the this is my experience. If you are happy with the sleeve, you've done it nice, you build up your experience, you have good results, good outcome, why not?
Who agree or who feels the big amount of faculty? Who prefer faculty? The
How do you consent the patients for that? Before.
Problem is, there are so many SBs, stomach is still big all the time. I'm able to anticipate that we start the normal analysis. Go ahead and do the round, and then they are so they avoid or it's a small thing and then they go.
Yeah, but the question is, Malik, if you are a patient asking, there is always saying patient asking.
Let me give you some of the history of this conference. Okay, in 2005, it's the government and the government. In 2005, the during the center for part of the me and the
Abdulhamid.
and National Guard. In 2006, our colleague and special hospital they started the lead and the reporting for the sleep 5%. So we had a problem with the sleep at that time. In 2005, when the credit for Johnson and Johnson because that time they introduced the action in 2005 as there was from our colleague was that we started with as big one, not experimental. In military hospital, while my group was in 2006, our colleague have an phobia of doing this like that. But when we reach the conversion from that to sleep, me and Sultan have been a scientific group. We are looking for all around. The percentage that we have, maybe 10% special hospital like conversion by Macalobina can more than 7%. The percentage in Jeddah come and he reported 15%.
Leak.
At that time, California G. You remember the grade and the 2G. So we discussed here why we compare from the procedure of 41 in part to 2% each to a procedure carried.
Excuse me for my friend in Zoom. I think we come to the end of this session. I hope that we provide you with a good scientific knowledge and information. Thank you, and we hope to see you soon, inshallah. Thank you very much.
Thank you, Doctor. Thank you, Dr. Sultan. And are we going to be open and a question and answer to the online attendees? Or
we will see because we are running short of battery here.
all right. Okay, Doctor. So thank you for the thank you for the attendees and I shall end. Thank you so much, Doctor. Thank you.
What is the risk of leakage.